Good evening, everyone. How are you all? Okay. So as we already discussed last time as well, that when you join our sessions, you need to make sure that you join with your own name. It cannot be your device name. So I can still see that some of your name is showing as HP, iPhone. So if you guys continue to do that, I will need to just stop adding you to the Zoom classes because it just takes a lot of time for us to go through this. So whenever you join the sessions, especially from Zoom, they always ask you to write your name. So if you don't write your name, it will come as your device name. So if you can please log out and rejoin this class and then just write your own name so that we know who you are. So I can only see two people in here, which is one name is HP and another is iPhone. So if you can please change it and rejoin. So tonight we are going to discuss statistics. So stat is important in a way that like you might just get like one or two questions in the exam. So it's not the super important topic for your exam, but there's a lot to learn. So sometimes the amount of things that you need to learn for statistics, it is not like super important sometimes. So that's why we normally don't go too much detail about a stat because there is no you don't get a huge amount of questions. And the questions that usually comes, that's usually like the common questions. So it gets common in the exam. So when you do the question solve classes with our mentors and the questions that we discuss, that's usually the one that comes in exam as well. Okay. All right. So for statistics, as you were seeing, I was just opening the Kaplan strip to CK. So for statistics, we don't go through any specific books because if you can learn some of the questions and learning those questions gives you enough idea about the exam questions, and that's more than enough to pass a stat in exam. So what we are normally going to do is to go through just a little bit of basic about a stat. Now remember, I am not also a statistician, and like none of us really learn stat in medical school as well. You only need it if you are interested in public health. So, so I'm not also best in this, but I'll try my best to give you informations and only the information which is needed for your exam. Nothing too deep, but nothing too shallow also. So whatever I discuss, you will understand it. I will make sure of that. But please don't think that the questions in the exam will be very complicated. And sometimes they do give the complicated stat, but most of these are like a pilot questions or unmarked questions. So nothing to worry about a stat. That's the deal. So if you really want to learn statistics, then you can read Kaplan Strip to CK. So if you go to Kaplan Strip to CK, if you just click on psychiatry, at the end, you'll see chapter, there is epidemiology and ethics. So this chapter 20 and 21 is the stat chapter. Okay. So starting with some of the common study design that we really do in case of a stat. So sometimes when we are talking about a stat, definitely study designs are important. So we do observational and experimental studies. So observational studies are you just observe. You allow the nature to take its own course. You don't do any intervention. Whereas there is experimental studies where you do intervene, and the result of this study assess the effect of the intervention. So whatever intervention you do, the result of that study usually will assess the effect of the intervention, which means that if you give a medication to a group of people, and after a couple of years, you check what kind of side effect patient has got, that's an experimental study. Okay? Now, we do both observational and experimental. As part of observational studies, we have case report, case series. We have cross-sectional study, case control, and cohort. So as case report or case series, they are not statistically significant. So if you take a history from a patient and you write a note about that patient, that becomes the case report. Whereas these are much more bigger and detailed study, which is cross-sectional and case control and cohort. If you look at this picture, it gives us an idea that what does it mean. So cross-sectional in the middle, cohort goes in the future, and case control go to the past. So cross-sectional study will be the presence or absence of a disease is determined in each member of the study population at a particular time. So in a simple way, when we do a study to know at that point of time in a particular community, if we want to know the presence or absence of a disease, like at the moment, I want to know in a particular suburb or community, how much people are diabetic. If I want to know that at the moment in a particular community or group of people, the study that I will choose is the cross-sectional one. In cross-sectional study, you can find out the disease prevalence, but you can't actually get the incidence of a disease. So these are two new terms for you. Prevalence of a disease means that when we actually find out both new and old cases. So total number of cases in a population is what we call prevalence of a disease. And the incidence is the number of new cases. So because in cross-sectional, we don't go forward, we can't actually know the new cases anymore. We can only know how much patient having a disease in that particular time, in that particular community. So in cross-sectional, you can get the disease prevalence, which include like all the cases, all the diseased patient in that community at that time. But you can't actually get the incidence. Whereas if we are talking about case control study, in case control, we identify a group of people with the disease, and then we identify another group of people without the disease. And then what we do is we go back to find out if there is any causal relationship. So what does it really mean? It means that let's say we want to know, like someone, if we make an example like this, like if we want to know that if a patient who has got, let's say, a very rare cancer, and we wanted to know whether this patient was exposed to any asbestos or exposed to any carcinogenic agent when he was working. What we are doing is that at the moment we know that patient has got a very unknown cancer or very rare cancer, and we went back to the past to find out whether this patient was exposed to some kind of insecticide, pesticide, or anything, any kind of like an irritant. When we go backward to find a cause of a disease, that's the time we do the case control. Because it goes backward, it cannot assess definitely the new case, and also it cannot assess the number of diseased people in a community because we are going backward. Okay, so that's case control, which goes backward. Whereas exactly the opposite is cohort, where we go forward. Let's say we take a group of patient who is a smoker, and we also did find a group of people who are non-smoker. And after 10 years, so throughout these 10 years, we normally do the experiment on them. We see if any of them are getting any cancer. So after 10 years, we found out whether smoking has any relationship with lung cancer. What we have done is that we went forward in the future and we tried to find out also the causal relationship. But this time we want to know that whether the risk factor, which was a smoking, caused the disease in the future. Okay? So that is what we will call as cohort study. So we do the cohort for more common disease. We don't do the cohort for uncommon diseases. And because we are going forward, we can actually determine the incidence of a disease, which means the new cases. So does it make sense for all of you that what is cohort, what is case control, what is cross-sectional? Okay, so in a simple way, if the easiest way to think is that if we want to find out number of diseased people in a community at a particular time. At the moment in your community, you want to know how much people is diabetic. What study you will do? Cross-sectional. You wanted to know that if a child who has Down syndrome, did he got any kind of anti-epileptic drug, or did the mother do any kind of Down syndrome screening during pregnancy? So when we go backward to find out any cause, we do case control. And when we want to know that, well, smoking causes lung cancer, so when we go forward, that's cohort. So that's the easiest way. I don't know what's confusing in here. It's very easy, very normal. So think about at the moment, we do cross-sectional. If we want to go backward, case control. If we want to go forward, cohort. Nice and easy. For incidence, best one will be cohort because we are going forward and we can easily find out the number of cases. For prevalence, best will be cross-sectional. Now, when we do the observational studies, sometimes we use few things to find out the math. So to analyze observational studies, we use few things called, one is called relative risk. You can read it if you like, attributable risk. So these are the two things that we use for analyzing the observational studies. Whereas for case control studies, we use odds ratio. So basically question asks that for cohort studies, what kind of like risk or what kind of calculation you need, or what kind of observational, like we say that how you are going to analyze a cohort study. So when question asks about analyzing a cohort study, we use relative and attributable risk. And for case control, we use odds ratio. Now, you really don't need to know what are them. You just need to know the name of them. So give it a read if you like, but that's what comes in exam. Okay, so that gives us an idea about the common thing. So this is the main basic, and many times question comes from this, that they give you a scenario and they ask you, what is the best study for this patient or for this group of studies? Okay, so let's start with some questions, and throughout the question, you will learn more and more. So first question is, which of the following can be used for data analysis in cross-sectional? So we just learned at the moment that for cohort, we use relative and attributable risk. For case control, we use odds ratio. And for cross-sectional, we use chi-square. So you just need to remember that which one normally we use for data analysis in each of these studies. Now, chi-square, how to measure it doesn't come in exam. Odds ratio doesn't come in exam. But yes, we need to know the relative and attributable risk, so which we will discuss during this time. So when we do some cases, you will know how to do it. Next question, which is the best study to find out the state of vitamin D deficiency in Australia? So what do you understand from it? So they want to know in Australia at the moment, how much people are vitamin D deficient? What they're asking, prevalence at a particular point of time in a particular community. What will you do? Cross-sectional. Okay. So anytime if question asks that you want to find out the number of diabetic patient in your community, what will you do? So whenever they want to know the total number of diseased patient in a community at a particular time, the choice is cross-sectional. Okay. Next. So the next question is about number needed to treat. So two groups are being studied for risk reduction for some disease with aspirin use. Tables are given as follows. Calculate the number needed to treat, NNT. So number needed to treat, there is a formula that we need to first know. So NNT equal to 1 by attributable relative risk or attributable risk. Now, to find out the number needed to treat, you need to find out attributable risk, right? Because if you find out attributable risk, you can easily do the math. So for attributable risk, that's where the math comes. So to find out the attributable risk, or we also call it absolute risk reduction, whatever it is the incidence of a disease, or you can say incidence in a exposed group, or you can say incidence in the non-exposed group minus incidence in the exposed group. So that's the main math. So attributable risk equal to incidence in the non-exposed group minus incidence in the exposed group. So now we need to find out what is the incidence in the non-exposed group and what is the incidence in the exposed group. If we come to this math now you can have a look that in here, this is the exposed group because this group of people was given aspirin. These people was not given anything. They are the placebo group. And you can see that people who took aspirin, only 10 people got, let's say, heart attack or a stroke. And people who did not take the aspirin, 20 people got the disease. Out of what? So total number of people is 990 plus 10. Out of 1,000 people, 10 people got the disease. So now we can do the math. So what is the incidence rate of the disease in the non-exposed group? So non-exposed, out of 1,000, 20 people has got the disease. That's the incidence. Minus 1,000. So in the exposed group, only 10 people got the disease. So 10 by 1,000. Okay. So that's the main math that you need to understand. It's quite easy if you know, if you did not forget about all the mathematical things. So once you do the math, so you can understand from here. So you just need to do the math. So now the problem in exam is that they don't give you any calculator. You have to do it in your head, but they give you a pen and paper. You can easily do it on a pen and paper. Okay. So does it make sense to everyone how we came up to this? Okay, now once we do the math, so 20 by 1,000 equal to 0.02 and 10 by 1,000 equal to 0.01. If you do the math, it becomes 0.01. So that's our attributable risk. So what is the number needed to treat? Number needed to treat equal to 1 divided by attributable risk. So 1 divided by 0.01. And you know that if we do the math, it becomes, so if we just remove the point, then we need to multiply by 100. So it means it's 100. So 100 is the answer in this case. Okay. So now I can't be a mathematics teacher for you, unfortunately. You need to remember that this is basic. So in exam, you need to at least know how to do a subtraction, how to do a division. That's the part of you, or if you forget about the math, go back and learn it. But this is very important to understand that these are simple math and no one needs a calculator to measure this. You can do it in your head. Okay, so no, you can't, because they will not allow you to use the calculator. So in exam, there is no calculator. Okay, so you have to do it in your, like, there will be a pen and paper. You can do it on the pen and paper if you like. Okay, so again, at first you need to find out the attributable risk, and then you need to find out what is the incidence rate in the non-exposed group minus incidence rate in the exposed group. We know from there that 20 people out of 1,000 has got disease and 10 people out of 1,000 got disease. So 10 people who took aspirin got the disease, 20 people who did not take the aspirin got the disease. So 0.02 minus 0.01, 0.01, and then NNT equal to 1 by attributable risk. So 1 by 0.01. So after point, there is two number. So if we want to just remove the point, we multiply by 100. Answer is 100. Okay. So that's about this question. Any questions? Anything you didn't understand? Yes, it's the same thing. Attributable risk and absolute risk reduction is same. So number 4, in a village of 3,000 people, 500 got Congo hemorrhagic fever. 450 eventually recovered from the disease in the next 4 weeks, while 50 died. What is the case fatality rate for the disease? So case fatality rate equal to total number of death from the disease. So what is the total number of death from the disease? 50. Divided by total number of cases. So we know that 500 was the total number of cases. So that's 500. So what will be the case fatality rate? Now, whenever there is a rate in the exam, we multiply by 100, right? So 10, 10. So 10 is the answer. All right? So see that it's not really very difficult. So all you need to know is this formula. So total number of death from the disease was 50 divided by total number of cases. Now, number 6 is a very controversial question. I will come back to it later on if needed. We'll go from there. Don't want to scare you now. In a small village of North Queensland with a community of 3,000 people, 18% female got upper respiratory tract infection, while 22% male also got it, who are exposed to the factory smoke. 10% female also got the infection, but they live away from the factory, not exposed to the smoke. Calculate the attributable risk for females to get a upper respiratory tract infection due to factory smoke. So they're asking you to measure the attributable risk in female. So we will forget about the male, and we want to know what is attributable risk. So incidence rate in the non-exposed group minus incidence rate of exposed group. Now remember, they already gave you the percentage, 18%, 10%. So you don't need to do any math in here, like the one that we have just done. So what is the incidence rate in non-exposed group? We know that 10% female also got it. And incidence rate in the exposed group was 18%. Now, in attributable risk, we never use minus. So it becomes -8, right? So we never use minus in this. So you just turn the math. So what we do in this case is incidence rate in the exposed group minus incidence rate of the non-exposed group. So in the exposed group, it was 18%. Non-exposed group, it was 10%. So okay. So when percentage is given, it's very easy. But sometimes we need to find out the percentage, then it becomes a bit tricky. Okay. Now, a study wished to make a relationship between fatigue in a truck car driver in highways and the incidence of motor vehicle accident to carry out a study. Now, this is where you need to use your brain. So you want to find out that fatigue in a truck car driver with the incidence of motor vehicle accident. Okay, so if we want to find out this by a cohort study, can we do it? Do you think? Because if we want to do a cohort, we have to find out that, well, let's make the truck car driver fatigued by not allowing them to sleep for 24 hours, and then see if they can get a motor vehicle accident. Because that's how we go forward. We do the cohort. So yes, we can't do that. The only way to do this study is if we find a group of motor vehicle accident and we find out whether they were fatigued during driving. So what are we doing? We are going backward to find out the cause, right? So that's the time we use a case control. So case controls are used in this kind of scenarios when you can't go forward, and mostly because of ethical issue. That's right. Next question, what is the least important study to look for effectiveness of CCF treatment? So many times they ask that what is the best study? What is the least important study? So the least important is case series or case report. They are the least effective or least important. because you're just taking one patient's history. And you can see in the pyramid, the best study is meta-analysis and then systemic reviews. And after that, we have randomized control trial, then cohort, then case control, then cross-sectional. So sometimes they ask this kind of questions. So meta-analysis is the best. You found that there are more and more diabetic in your practice, and you want to do a research about how many people are diabetic. So now you understand what they're talking about, right? What is the best study design? So definitely, if we want to find out like how many people are diabetic in my community at this time, we want to do a cross-sectional. Whereas this question asks if you need to study whether smoking causes myocardial infarction. So see that how the question are getting asked. Smoking causes. So cause to effect. When we actually look at like this, cause to effect, cause is smoking, effect is MI, then we are moving forward. And that's the time we go for a cohort study. Okay? And it's a common risk, common association that is smoking can cause MI. So those kind of scenarios, we go for cohort. Have a look at this one. A young scientist has decided to study the causes of neonatal jaundice. He selects 150 babies with jaundice and 150 without, and examines their previous histories looking for factors that could have determined their jaundice. What is this study called? So you can understand what the young scientist is doing. He wants to know the cause of neonatal jaundice. He selected 150 baby with jaundice and without, and examined their previous histories. So he went backward to check the previous histories to find out any factor that has caused this neonatal jaundice. So when we go from effect to the cause, so we are going back. We already know the effect, jaundice. And now we are going to find out the cause. So when we go backward, that's the time we do the case control. Okay? Does it make sense to everyone? So don't think too much complicated in the exam. That I know that if you think like this, that, well, if I think I want to know, I know a group of patients who got MI, and I wanted to know that whether they were smoking. Yes, we can do case control in that way, but the question did not ask like that. Question asks that whether smoking causes MI. Did question ask whether MI is caused by smoking? No. So it depends on what question asks you. The question directly asks you that you want to know whether smoking causes MI. So cause to effect. That's the time we go for cohort. Okay. So don't think too much complicated. That's always the best advice I can give any of you. Okay. Now, this is a question which will give you a little bit of headache, but let's go for it, right? So I think you are ready. So 2 into 2 table. 2 into 2 table are used in a lot of stat to find out lots of things: sensitivity, specificity, true positive, true negative, false positive, false negative. So a lot of things come out from this 2 by 2 table or 2 into 2 table. So understanding the 2 into 2 table is really, really important. Okay, so let's go through this a little bit. So classic 2 into 2 table is like this. So in 2 into 2 table, if you look over here, so there are a few things that we look into. So we look into diseased population, and disease-free population. We look at test positive and test negative population. So first of all, you need to, the best way is to just memorize this table because it will come in handy in a lot of questions. Now, you need to understand what does this true positive, true negative means. So let's say a test came back positive for a disease and patient is actually diseased. Okay, so when a patient test says that yes, this is positive and patient is actually a diseased patient, that test is truly positive or true positive. Okay, test said that yes, you are positive for something, but patient was not actually diseased. So the test was falsely positive because test said that yes, you are positive for a disease, but the patient actually did not have it. So that's false positive test. Test came back negative, but patient ended up getting a cancer. That means test was false negative, or I remember by falsely negative. Test negative and patient does not have any disease. That means test is truly negative. Okay? So if you remember in this way, it is not very difficult. Otherwise, it can be. So first of all, we need to understand what is true positive, false positive, what is true negative, what is false negative. Does it make sense? Do you guys understood? Did you guys understand what I said about this? Great. Now, if you look over here, that in the classic 2x2 table, this also helps us to find out few things. So it helps us to find out sensitivity of a test and a specificity of a test. So first of all, we need to know what is sensitivity of a test. Sensitivity of a test is the proportion of people with disease who are correctly classified by the test as positive. Again, let's say a good screening test will be able to find out anyone who can have a disease. Okay? So a good sensitive test means that it can identify almost every diseased patient. So a test has high sensitivity if it can find out that group of diseased patient. Let's say among 100 patients who took a test was able to identify 90 people with the disease. And 10 people, the test was not able to identify the disease. That means that this test is 90% sensitive, which means it's highly sensitive. It can find out almost all the diseased people. Okay? So that's sensitivity. And in a 2x2 table, the sensitivity is located in the left column. So this left column usually measures the sensitivity. How we measure sensitivity then? So sensitivity equal to true positive divided by true positive plus false negative. Have a look. So sensitivity means or equal to true positive divided by true positive plus false negative. So it's in the left column. And you can now understand how the math actually is working. So you can see that this group is the number of total diseased people. So true positive plus false negative. So they are the diseased people. And the test was able to find out only this. It missed this one, these people. So sensitivity equal to among the total number of diseased patients, how many people this test was able to say, yes, you have got the disease? Does it make sense? It is a bit tricky, but I hope it makes sense. So that's how we can measure the sensitivity of a test. In the exact same way, a specificity means it's on this right column. And if we want to find out the specificity of a disease, what does it really mean? It is the proportion of healthy people who the test says, yes, you are healthy. So it is the number of people who the test says you are truly negative out of the people who did the test. So out of all the people who the test said healthy, what is the number of people who was actually negative or who are actually disease-free? That's how we find out the specificity. Again, specificity equal to true negative divided by true negative, false positive. So this column identifies the specificity of a condition or of a test. So specificity means that out of all the healthy people, how many people the test was able to say that, yes, you are healthy. So that's specificity. Okay? So that's how we find out the sensitivity and specificity of a test. Now, these two, sensitivity and specificity, determines the test validity sometimes. Now, there are two other things, which is positive and negative predictive value. To find out the positive predictive value is basically the top row. So top row decide the positive predictive value of a test. So it is the proportion of people with a positive screening test who are actually diseased. So if we look over here, so this top row gives us the positive predictive value of a test. So out of all the people who the test said, so the test positive, out of all the people who got positive test, how many people was actually diseased? So the how we explain it is a bit different. Okay, so in here, it's not about how many diseased patient. It's about how many people the test said positive. So that's this. Who was actually positive? And the negative predictive value of a test is how many people test said negative. So that's this group, true negative, false negative. Out of this, who was actually negative? Okay. I hope it's not complicating, but if it is, you can just easily remember that left column gives sensitivity, right column gives specificity, top row gives positive predictive value, and the bottom row gives negative predictive value of a test. Okay? Now, this comes in handy in exam because in exam, they will not say what is the sensitivity or measure the sensitivity of this test. They will just ask in a way that you need to know what they're asking for. So they can say that we'll find out the number of people who was tested positive and they are actually diseased. So if they ask, find out the proportion of people with a positive screening who actually came as diseased. What does it mean? It means they're asking about finding out the positive predictive value. So if you don't know what PPV means, you will not know what the question is asking you. And usually exam doesn't make it like very complicated. So many times I haven't seen this to come often in the exam, but it is something good to know. Now, the reason why we had to discuss all of this is this question. So let's have a look. So a scientist study a case which is 30% false positive and 10% false negative in a study of 1100 students. Now the test shows 100 people are positive for the test. So we know this is test positive, this is test negative, this is diseased, this is non-diseased. This says that out of 100 people who are positive for the test. So we know the test positive total number is 100. Now remember, this is not given in the exam. You need to do this. And we know that 30% is false positive. And false positive is over here. So this 30 will come there. Right? Now, out of 100, if 30% is false positive, how much is true positive? 70, because 70 plus 30 equal to 100, right? So we can easily find this out. And we also know that 10% is false negative. So this 10% is false negative. Now the question was actually asking for positive predictive value. So the question will be like something like, find out the proportion of people who the test came back positive and they're actually diseased, something like that. Now this is definitely not the full question, but the full question will be something like, find out the proportion of people who was tested positive and they are actually diseased. So to find out the positive predictive value, we know it is the top row, which is needed. And we know that to find out the positive predictive value, we need to find out true positive divided by true positive plus false positive, because it's all about the top row. So we know true positive equal to 70 and total is 100. And we just multiply by 100 because we are just doing the rate or PPV rate. So 100, 100, and this is 70. Okay, so that's the math. The math is not very difficult. If you can remember the 2 into 2 table, then it's quite easy. And if this is a marked question in the exam, this will be the something which will carry high mark. Okay, because it takes a lot of effort to come to the right answer in this case. Okay. Nothing. That 1100 has nothing to do. Clear, everyone? Any questions with this 2 into 2 table? A new drug is being tested for decreasing mortality in a hypertension patient by 1/4. In a community of 100, you have 8 patients with the condition. What is the number needed to treat? Now, the questions becomes a bit tricky when it is not a full question. Left side of the table shows sensitivity, and the right side shows a specificity. Okay, so this is not a full question, but I'll try to decode the question. So number needed to treat equal to 1 divided by attributable risk. We want to know what is the incidence rate in the exposed group minus incidence rate in the non-exposed group. Doesn't matter, anyone can come to the front. Now, In here, in a community of 100, you have 8 patients who has the disease. And this group is the one who is not exposed to any medication. So the question is asking something like that. So out of 100 patients in a community, 8 people has the disease and who is not with any kind of medication. So what is the incidence rate in the non-exposed group? 8 out of 100. So 8 divided by 100, that's the incidence rate in the placebo group or the non-exposed group. What is the incidence rate in the group who are getting this new drug? So they say that a new drug is being tested and it can decrease the mortality in hypertension patient by 1/4. So this new drug has reduced the mortality by 1/4. So what's 1/4 means? 1/4 means that previously 8 people was dying because of hypertension. Now it has reduced that number by 1/4. So what is 1/4 of 8? 2. So now previously 8 people were dying without the medication. Now this new drug is saving these 2 people. So how many people are getting the disease even after the new drug? Guys? 6 people. Okay. So 6 out of 100 are still getting, are still dying because of this medication. So now we just need to find out that what is 8 by 100 and what is 6 by 100 means. So if you do the math, you will find, so 0.08. So because this is a bigger number than this, you will just make it 8 by 100 minus 6 by 100. So 0.08 minus 0.06, so 0.02. So you just do the math, 1 by 0.02. So you remember, if you need to withdraw that, you multiply by 100 because there is 2 number after the point. So your answer is 250. Okay. Now again, don't get confused from the question because the question is not full question. Actually, the question wanted to mean, or the full question in the exam will be something like that. Like they would say that 8 people has the condition, or you can say 8 people are dying without the medication. So previously, without the medication, 8 out of 100 was dying. Now, after the new drug, that number 8 has been reduced by 1/4. So new drug has reduced the mortality by 1/4. So previously 8 people was dying. Now 1/4 means, what is 1/4 of 8? 2. Now 2 people are getting saved, which means 6 people are still dying. But the new drug is saving at least 2 people. So the incidence rate in the exposed group, so definitely exposed group is the new drug people, right? Not these people, they are the non-exposed. So 6 by 100 is the exposed group, 8 by 100 is the non-exposed group. Does it make sense? So many writing. Wow. Exam does not, yes, I was saying that. So exam allows you to use a pen and paper, so you can calculate. So yes, you will have a pen and paper. All good. Any question, guys? Yes, they provide normal lab values in exam. Yes, most of the time they would provide it to you, so you don't need to memorize it. Okay, so I'll take a 10-minute break now, and then we'll start from the rest of it. And as part of some lifetime advice, you are going to be a doctor in Australia. And that's why you are preparing for this exam, right? And from now onwards, you need to also, it's not just passing the exam. So you are passing the exam, maybe AMC, MCQ, but if you want to pass your clinical exam, you need to know how to talk to your patient, to anyone. So understanding politeness when you talk, it's very important. Especially you need to, whatever you say, whatever you write, you need to say please. You can't say to anyone, just do this, do that. It is so impolite to say something like that. I know that like many of you don't mean it, but because I have been working here for like more than 10 years, nowadays that my tolerance for this kind of like talking is really low, because I forgot, because when I used to work in my country, I used to say things like this. But now, because even with 10 years younger than me, I will always write please, thank you, all of this. Or when I say something, I always say please. Using please in your word is a norm in Australia or any countries where this norm is actually followed. So my recommendation for all of you is that whenever you talk, whenever you say something to anyone, whether it's your junior, your senior, always make sure you say please. Okay? Because that's really important. Showing respect is not just for your elder, also for your younger. So, and even like when you talk to your partner, talk to your wife or husband, you can't just say that, do this. It's not really good. Okay? So respectful behavior starts from now. Okay? So I hope you understand why I told that. No worries. Let's take a 10-minute break. Thank you. All right, everyone, let's restart again. So we finished up to this. So next is, no, these are not given in Kaplan. So these are like all the questions throughout the years we just collected and we just made a note out of it. So this gives you a good idea about the questions that can come in exam. And definitely it also like it includes everything that you really need to know. So after this, you don't really need to know anything, especially about a stat, unless something new comes in your exam and you'll get it during your question solve classes. Okay, so you want to make a study about asthmatic patient and if there have been any exposure to smoke or its severity to exposure to smoke, which study is most appropriate. So they said you want to make a study about asthmatic patient. So that means you already know the effect. So effect is asthma, and they're asking you to know whether they have been exposed to a smoke. So when we already know an effect, which is asthma in this patient, and we want to go back and find out if there has been any relationship with smoke exposure, what would you do? We would go backward to find out the case control, or it depends on how the question comes in exam. If questions say you want to make a study about whether smoking causes asthma, that will become cohort. If they say that you want to know about a group of asthmatic patient and you want to know if they have been exposed to a smoke, so a total different thing to say. So how the question asks, that really defines what kind of study we are doing. So if question gives the disease first, that we want to know if we want to know about asthma patient and we want to know whether they have been exposed to a smoke. So they're giving cause, they're giving effect to the cause. So when they do effect to cause, that becomes backward, which is our case control. Okay. Like this one is different. A study being planned to investigate the effect of exposure of pesticide on incidence of cancer. See that how the question comes. So they are asking the cause. Cause is exposure to pesticide and effect is cancer. So when they say you want to study whether environmental exposure to pesticide causes cancer, and they already said incidence, and incidence is usually done by cohort anyway. You can't do case control to find out the incidence. So that's cohort study. Okay. So these type of questions come more in the exam. Like they just give you a scenario and they ask what study is the best. Now, this is a tricky question. So they give you this kind of like a screening test diagram, and this will be given, and then they say the cutoff point of the screening test is increased. So this is the cutoff point. So this will test your knowledge about the 2 into 2 table. Okay. So you can see that this side is the healthy people and this side is the diseased group of patient. And in the healthy group, definitely true negative is the main group. And in the diseased group, true positive is the main group. So when these two intersect each other, this is called the cutoff point. And you can understand that diseased people include true positive and false negative, right? So these are the diseased people. And healthy people, true negative people, and false positive people, they are also healthy, right? Now they're saying that if you increase this cutoff point up to this, let's say, see if we increase the cutoff point, what are we doing? We increased the false negativity. So if we increase false negativity, and we decreased the amount of false positive, what we have done with sensitivity and specificity? That's the question. Now, up to this, is this clear that what has increased and what has decreased? Yeah, good. If you understand up to this, then think about that sensitivity looks at the diseased people, right? And specificity look at the healthy people. If you understood what we talked about in the 2 into 2. Now, in here, we know that sensitivity depends on true positive and also this false negative group over here. But now we have increased the false negative group. And what was the sensitivity of a test? Now, then we need to go up to give you a little bit more idea. So forget about this annotation, it will work later on. So if you remember, the sensitivity equal to true positive divided by false negative and true positive. Okay, so sensitivity of a test means that proportion of people with the disease who were correctly classified by the test as positive. That means the test was able to say that, yes, you are positive. And when it say positive, that people has the disease. Okay. Now, let me go back. Now, I know it is still confusing, so don't worry. I'll make it easier. So what we want you to understand that whether you can remember, if sensitivity means the test is able to define that, yes, you are truly positive. So the test was able to say, yes, you are positive, and patient is having the disease. Now, if suddenly false negative increases, means that test was not able to say that, yes, you are truly positive. So basically, what we have done by increasing this cutoff point, we reduced these true positive people and we increased the false negative. When the test is not able to say that, like, even if the test say, yes, you're truly positive for the disease, but it's not. That's why false negativity increasing. Okay. So when we increase the cutoff point, what we do is we increase the false negativity of a test. And false negative means the test is not able to find out the diseased people. And when a test not able to find out the diseased people, it means the test is not sensitive enough. So what we have done, we have reduced the sensitivity by increasing the cutoff point. And in the same way, we reduced the false positivity. And sensitivity, specificity means if the test is specifically able to say, yes, you are truly negative. By reducing the false positivity, we have increased the true negative part. When the test is able to say more that, yes, you are truly negative, that test has high specificity. Okay? So by increasing this cutoff point, the easiest way to remember that when you increase the cutoff point, you actually increase the number of true negativity. And that means the specificity of the test has got increased because the test is now able to say, yes, you are negative, and patient is actually negative or healthy. Okay, I hope it makes sense. If not, then just remember it. So if cutoff point of a screening test is increased, if we increase the cutoff point, of a screening test diagram, we increase the true negative, we decrease the true positive. If we increase true negative of a test, the specificity increases. Okay? If we decrease the true positive of a test, sensitivity decreases. So that's the baseline. So sensitivity has decreased, specificity has increased. Okay? Is there anyone who understood it or no? No one understood it? It will be repeating. Good. All right. Thank you, guys. Okay, moving on. So, Australian government appointed you to go through a community-based service and help a local doctor there. Hepatitis B data given in a community of a total population of 200. They need you to calculate the prevalence per 1,000 population in the year 2010. So you want to find out the prevalence of hepatitis B in 1,000 population in the year 2010. So we're looking into 2010. Now, hepatitis B prevalence means all the patients who got diagnosed with hepatitis B, the new and old. So it means whether they are antigen positive or antibody positive, all of them are diseased, or at some point they had the disease. So total number of people who has the disease or who had the disease, so 15 plus 55 divided by the total number of population. So total number of population is 200. So out of 200 people, this is the number of people in 2010 who had the hepatitis B, right? And then they say per 1,000 population. So multiply by 1,000. So 15 plus 55 is 70. So 70 by 200 into 1,000. So 200, 5, 3, 350. Okay. So that's your answer for this. So if they ask 2009, then you'll include this. Okay. So depends on the question that. Now, this is how we mainly find out the prevalence of a disease in a community. Okay, so that's what they want you to find out. Next, so they just said cutoff point has increased. So they did not say that it decreased. If cutoff point is decreased, that will go towards the true negative. If cutoff point is increased, it means we are moving forward. No, we don't need to know about the positive predictive and negative predictive value. That's too much complicated. So just remember the sensitivity and specificity, that will do. Which study is most reliable for outcome of a disease in a community? So if any time the question asks this kind of question, what is the most reliable test? Out of any test that we do, meta-analysis and systemic review is the most reliable test. If that is not in the question, you just go down. So we know that first meta-analysis, then systemic reviews, and then RCT. So we have RCT in the option. That's why we are going to choose this. So it's called randomized controlled trial. In randomized controlled trial, especially if we do a double-blinded RCT, what we do that we find a group of patients who are the experimental, where we are going to do the experiment, and we find a group of people who are just going to be the placebo. And then we do intervene, which means, let's say we are starting medication to the experimental group, And then over time, we just find out whether the medication is helping it or not. So we intervene. Now, randomized controlled trial means that you don't choose who is going to be the experimental group and who is going to be the placebo group. You just find it randomly. Okay, so when we do random choose between the experimental and placebo group, so it's called randomized controlled trial. So you don't know like who you are choosing as an experimental group. You don't know who you are choosing for placebo group, because that actually reduces the bias if you don't know who are experimental and who are placebo group. But someone else might know that, yes, this group will take the medication, this group will not take the medication. But when you are really the main person of like finding out the test data and everything, you would not know. That's called double-blinded. So you don't know who is the placebo, who is the experimental group. But yes, someone out of these people is getting the medication, someone is not. And then after years and years, you just find out that if any kind of effect has happened in this group of people. So yes, meta-analysis and systemic review. A post-marketing drug surveillance study of a new heart failure treatment to the market was carried out on 10,000 subjects who had completed clinical trials. Which one of the following most accurately reflects the information generated from such a study? So the question is asking that when you have already created or developed a medication and it is in the market now. When a drug is in the market, what is the most important information you will look for? So when it is in the market, the main thing that we look for is the side effect profile in the general population. So the post-marketing survey is basically to find out the adverse effect profile, because now it is in the community, it's much more diverse, and we can find out whether there is any adverse effect or not. Okay? What study would you do if you want to find out the efficacy of a vaccine in a group of people? Same question. So if there was anything better, we would choose that. If not, then RCT. Treatment group has a mortality of 20% and mortality in the placebo group is 40%. What is the relative risk of death with the new treatment? So the full question is, a new treatment has been added for a disease. The new treatment group mortality rate is 20%, whereas the people who is not getting the new treatment mortality rate is 40%. They're asking what is the relative risk of death with the new treatment. So remember, we were talking about attributable risk and relative risk. So this is where relative risk comes. Relative risk equal to incidence rate in the exposed group. So in here, that will always be in the numerator, divided by incidence rate in the non-exposed group. And this non-exposed group will always be in the denominator. So what is the incidence rate? They have already done the percentage. So we know incidence rate in the treatment group is 20%, and incidence rate in the placebo is 40%. So what is 20 by 40? Half or 0.5? So that's your answer. Okay. A new screening test was developed for a disease. According to the survey, there is an increase in percentage of people who are taking the test. So a new screening test has been added. People are taking the test, but there is no increase in number of people diagnosed with the disease. What is the underlying cause? Now, a screening test is developed to find out diseased people in the community. if a screening test is not able to find out the diseased people, what does it really mean? It means that it is not sensitive enough, right? Because we normally implement a screening test when it has high sensitivity. And high sensitivity means it can find out more and more diseased people in the community so that they don't end up getting a cancer. Same as the cervical screening test, right? So because it has high sensitivity, that's why it is a screening test. And that's the reason we do this, because if we can find out a HPV positive patient in the earliest stage, we can actually prevent to have a cervical cancer. Now, in your community, people are taking the test, but the test is not able to find out any diseased people. Means it is not sensitive enough. Okay? So the answer would be test has low sensitivity. A new drug is discovered which affects the progression of the disease, but not the mortality. Which is the most appropriate statement? Now, this is a bit tricky and a bit confusing also for some people. So let's say pancreatic cancer patient. We know it is bad. A new drug, a cancer treatment has been discovered, which can previously, within 1 year, patient would die. So high mortality rate. Right? Now with the new drug, patient is at least getting a 5-year survival. What's really happening with the new drug? People are not dying as early as it was. When mortality reduces for a condition like this, morbidity increases. Because now in the community, there is more and more sick people who has the cancer and they are not dying because of it. What did it do when it reduced the mortality? It increased the number of people in the community who has the disease. And what does it mean? It means it has increased the prevalence of the disease. Does it make any sense? Yeah, very good. All right, so that's a bit difficult to understand because that's not what we expect with this question, but this is what happens. It's not bad, but yes, because now there is more people who has the cancer because they're not dying, right? So next, a pharmaceutical company before the start of the trial got approval from ethics committee to use a new anti-cancer drug for carcinoma pancreas. The ethics committee gave approval and set the p-value as less than equal to 0.02 for the drug to be superior to other drugs. At the end of the trial, the company claimed about the efficacy of the new drug, that yes, it is superior to all other drugs in the market, but it found the p-value as 0.04. So ethics committee set it that it has to be less than 0.02. Now it is claiming that yes, it is efficacious or it is effective medication, but it did not fulfill the ethics committee p-value. What does it mean? It means new drug is safer, new drug is as useful as other drug, new drug is superior, definitely not because it did not satisfy the p-value. New drug is not superior, new drug is inferior. Now remember one thing, that this test was this study was done to know whether this drug was superior to other drug. That is the only thing that we can comment. We don't know if this drug is as effective as other. We don't know if this drug is inferior to other. We only can find out whether this drug is superior from this study. And that we know from the p-value that it's 0.04, and it did not get the target value, which means it is not superior. That's the only comment we can do. We can't say it is safer, we can't say it as useful, we can't say it is inferior. Okay? So p-value, if it is not set by an ethics committee, the set value for p is 0.05 and less than 0.05. But in this case, it was set as 0.02. Okay, but if it is not set, then 0.05 is the ideal one or usual ones. But sometimes the p-value, the ethics committee can set a specific value. Okay, so that's about p-value. Now, I'm not going to bombard you with this type 1 and type 2 error. You can go through this in your own time. Not very important for exam. Very rarely sometimes can come, but you can give it a read if you like. Next, as a GP in rural area, you noticed that recently more cases of hepatitis C has been diagnosed, and you want to do a research to find out the incidence of hep C in the community. How will you get information you need for the research? So you want to do a research about incidence, that means the new case of hep C. What information you would need? You want to find out number of all patients with hep C antibody positive, hep C antigen, hep C PCR, or all cases diagnosed as hep C in the last 5 years. Now remember, if they're asking new cases, the only way to find out the new cases is to find out who are currently hep C PCR positive, because they are the only one who has active disease at the moment. Okay? If they ask about prevalence, for prevalence, you can find out like the antibody level, because then you would know how much disease people are there. So antibody plus hep C PCR. But for incidence, only thing we really need to find out is the number of people who has hep C PCR positive. How to choose sample for a research of obesity in a community. So sometimes question asks this type of thing, that how are you going to choose a sample? The best way to choose a sample is random. So randomized in a general population is the best way to choose a sample for anything. Okay? A 15-year-old boy wants to participate in a research study. He told his parents, but parents did not agree. He lives with his parents. Can this boy participate in the research? No. So a minor, which means less than 18-year-old, and if they're not independent, that means minor living with parents, they are not independent, they need parents' consent for any kind of participation in a research study. So the minor cannot participate in a research study if parents don't give the consent. Okay, especially if they're not independent, like this boy. What is the advantage of a randomized control trial? We talked about it because it removed the bias, right? So most important advantage of randomization is that you really don't know who is the placebo group, who is the experimental group. So you can't do any kind of bias because you don't know. Okay, so the observer bias is important because you are the person who is observing this group of people. And if you know that, yes, this is the person who is getting the treatment, you can get biased. So choosing people randomly and not knowing what they are, it just removes a lot of bias. In a community, people are taking the pap smear, but there is increased incidence of carcinoma cervix. What does it mean? Failure to screen the high-risk women, inability to test or inability of the test to identify the disease in the earliest stage. Now you understand, because we just discussed that if people are taking the test, but the test is not able to find out the disease in the earliest stage, then yes, there will be more incidence of CS cervix because the test was supposed to get it in the earliest stage. So that means this test has low sensitivity. Okay, so that's what they're asking, inability of the test to identify the disease in the earliest stage. Okay, now we are moving into something else, which is like this. So this is called standard deviation. Now, if you get this kind of question in the exam, should be happy because it is very easy to do. So a standard deviation looks like this. So the only thing you need to memorize is if they're saying one standard deviation, 68% people fall into this one standard deviation. 95.5% people fall into two standard deviation. And 99.7% people fall into this 3 standard deviation. You just need to memorize this number. So up to 68, 1 standard deviation, up to 95.5, 2 standard, 97.7, 3 standard deviation. Now, this will come in handy later on when we do this question. So they're asking about average BP in a community is 130. That means blood pressure is 130 plus minus 25. About 95% people's blood pressure will be in what range? So if average blood pressure is 130 plus minus 25, 95% of the people in that community, what will be the range of their blood pressure? That's the question. To do something like that, we use a standard deviation. So in here, what we just do is 130 plus minus standard deviation into 25. That's the math. So everything is same. You just need to bring the standard deviation and multiply by this 25 here. So they're asking 95. 95 means 2 standard deviation, right? So 130 plus minus 2 into 25. 130 plus minus 50. So you can do the math. 130 plus 50. That's 180. And then we have got 130 minus 50, which is 80. So the range of blood pressure is between 80 to 180. So that's your answer here. Okay. It's easy, right? Any question with a standard deviation? So they can give a lot of questions from this standard deviation. All you need to know is to know this math. And as long as you know it, it's not very difficult. If they would say about 60% people would fall in what? So if they would say anything below 68, then you would multiply by 1. Okay, so it depends on the standard deviation. So same question in here, so you can do that. A pharmaceutical company contacts you and suggests you to start prescribing the new antidepressant. What criteria you will first look? So any new drug, the first thing you check before you start prescribing it is if this is approved by the ethics committee. So the ethics committee, then the Therapeutic Good Australia, TGA, if these are the one who needs to approve the medication before you prescribe something. So the first thing you would look at is whether this medication has got approval from ethics committee. Next, an experienced group of surgeons report on a randomized placebo-controlled trial comparing a particular surgical procedure for carotid artery to a sham procedure. The study concludes that using this advanced method reduced the risk of a stroke from 5 to 4%, and the p-value is less than 0.05. What does this study proved about the new surgical method? So the question is that an experienced group of surgeons has done a report on a trial comparing a particular surgical technique. So a new surgical technique has been studied by a group of surgeons, and they found that yes, the new procedure reduced the risk of a stroke, and they also satisfied the p-value. What does it mean? It means that the new surgical method is effective, or it has high efficacy. Now you can see that both effectiveness and efficacy is in the option. I think it is wrong because these are same thing. And you can see there are 6 options in here. So it is most likely something wrong that we got from the recaller or something, but it's the same thing. So when a study find out that it satisfies the p-value, it means it is effective or it has high efficacy. Okay. Vitamin C efficacy on influenza with placebo. What to do to increase the validity? So the question is how we can increase the validity of a test. Randomization, always. So randomization is the best way to increase validity, sensitivity of a test. Now, this is another question which comes in exam. So I have seen this. Now, they give you this screening test diagram, and they also point A, B, C, D, E like this. And they ask you that which point has got 100% sensitivity and which point has got 100% specificity. Now, again, this will test your understanding about sensitivity and specificity. So sensitivity means a test has 100% sensitivity if it doesn't have any false positivity. Sorry, any false negativity, right? So we remember that sensitivity means it includes true positive and false negative, these two. Now, at this point, so at this B point, we don't have any false negativity. Okay, because this is where there is no false negative. So everything is truly positive. So if they ask where you get the 100% sensitivity is the point B. In the same way, when there is no false positivity, that means here, everything is truly negative. That means D point has 100% specificity. That is the only thing that you need to remember. Okay? Make sense for everyone? Clear? Because this has to be clear. This comes in exam a lot. So you just need to find out where there is everything is true positive. So at B point, so first thing you need to remember, 100% sensitive test means everything is truly positive. So which point has everything true positive? So we can understand that this is the point where there is no false negativity. So this point has everything true positive. Okay? Because false negativity is this bit. But at this point, there is no false negativity, right? So B point has highest sensitivity, and point D, there is no false positivity. Everything is truly negative. So if a test is 100% true negative, that means it has like 100% specificity. That's the case. So The easiest way to understand it that when true positive of a test is like 100%, it has 100% sensitivity, which is the point B. And when true negativity of a test is 100%, which is at this point, because in here there is no false positive, everything is true negative, that test, that point has a high or 100% specificity. Okay. Now again, if you can't understand even after that, very easy to remember. In a community, survey is being conducted for 200 people. This is the data that has been given in 2009 and 2010. Blood pressure, fasting blood sugar, high cholesterol, everything. They want you to calculate the incidence of hypertension in 2010. So again, this one, what we are looking at. So incidence of hypertension in 2010. In 29 or 2009, 45 people has blood pressure problem. And in 2010, 50 people. So how many new people has got the hypertension in 2010? 5 people, right? Now we need to find out, so how many people? 200. So out of 200, 5 people has got the new disease. And always remember that if they don't say like per 1,000 in your question, incidence and prevalence is always measured per 1,000. So you do the math, 200, 200, 25, 25. So 25 is the incidence rate of hypertension in 2010. Okay, so out of 200 people, 5 people has got the hypertension as a new case because they're asking about the incidence. And incidence means new case. Next, a company want to study regarding effectiveness of a drug. What will be the null hypothesis of this study? Now, this is one of the things which no one likes to remember or no one actually wants to know, but you just understand what I'm saying now. So a company wants to do a study regarding effectiveness of a drug. And what will be the null hypothesis of that study? So null hypothesis means that any kind of study result that we get in a statistics, everything is just by chance. Okay, that means we're not doing anything, we're just getting the result out of nothing. So that's the null hypothesis. For a study to become significant, that study needs to reject the null hypothesis. And once a study can reject the null hypothesis, which means the study can prove that no, my result is not just happening by chance. I have introduced this thing, or I have invented or discovered this medication, and that's why I'm getting this result, which means I am rejecting the null hypothesis. When a study can reject the null hypothesis, that means it is significant. Okay? So the question is, what will be the null hypothesis of this study? So no change in efficacy between two drugs. So null hypothesis will say that that between the two drugs, there is no change in efficacy. All the drugs are equally fine. So the only way you can actually say your drug is more effective is when you say, no, my drug is more effective and I reject this hypothesis. And if you can prove it, that means your study is done or it is significant. So when you start a study, you need to reject the null hypothesis for this study to become significant. Okay? What is the most appropriate study design to explore the association between depression and binge eating in a population of obese adolescent, and adult. Now, we can do a lot of study for these kind of things. We can do cohort, we can do cross-sectional. If the question just said that you want to do a study to find out the relationship between depression and binge eating, then in that case, you can do a cohort. But they said they gave you a specific group of people. When they give you a specific group of people in a given time, that's the time we choose the cross-sectional. Okay, so the most, and you know that cross-sectional can do the causal relationship, right? So it can actually do the association or relationship between the cause and effect. So if we want to know that in a group of community where most of the people are obese, adolescent, and adult, so we are just choosing that particular community, and we want to know, like, what is the relationship between binge eating and depression in that particular community? The best one would be cross-sectional. Okay, so if they specify a specific community or a particular community, then we choose the cross-sectional. What is the most appropriate design to explore long-term effect of detention on the mental and physical health of asylum seeker? So they're asking about long-term effect. So whenever they're asking about finding out the effect, means that they're asking about like the future. They already mentioned long term, which means we need to go to the future to actually find out the long-term effect, which means we are going forward. And that means we need to do a cohort study. What is the most appropriate study design to explore a relationship between folic acid supplementation during pregnancy and development of autism in the children? Now, this is also important to understand. Can you do a cohort study in here? To do a cohort study, you need to avoid giving the folic acid to some mother and see if their baby gets autism. So we can't do that. Only way is that when we get an autism child, we go back to the history and find out whether the mother took folic acid or not. So we're going backward. So that's case control. What is the most appropriate design to test a drug for use in elderly people diagnosed with Alzheimer's? So again, the best is always RCT, or like if any of the others are there. What is the appropriate step in designing a cohort study? Always, like, doesn't matter what kind of cohort study we are doing, the best or the most important step is to have a proper follow-up, because this is something which will go for years and years. And if you lose the group of patients who you are supposed to follow up, you can't actually do the study. So planning a proper follow-up is must for a cohort. You are planning on conducting a research to look at the association between hypertension and MI. So these are very common. Does hypertension causes MI? Does smoking causes MI? So this kind of things we normally choose cohort. Okay. Now, the last one is this forest plotting. Does anyone has any idea about forest plot? Or have you guys, like, anyone taught you forest plot, like any other mentors? Okay, so that's fine. So the way that it comes in exam is that they give you this forest plot, Yes, this is like a pooled result of meta-analysis, it's right. So let's say they have given you this kind of picture and they say that this is drug number A and this is drug number B. And they ask you that what do you understand from this? So if you have never seen it, you will not understand what it is. So there is a good YouTube video link here. You can read it in your own time, but you don't really need to look at anything except this diamond-shaped thing. These diamond-shaped things means that this side has better efficacy. If the diamond-shaped thing is here, then this side has the better efficacy. So wherever this diamond-shaped thing will be there, then you can say that either B or A is effective. If it is in the middle, then you can't say anything. It is not significant. Okay? So that's what you really need to remember from forest plot. There's a lot to learn from here, but it's not really needed for your exam. All you need to know that if you can understand what does it really mean. So look at this diamond thing, don't look at others, and that will make sense. Okay, so we don't really do this kind of, these cases we normally don't do, not really super important. You can go through it in your own time if you like. Sometimes this kind of questions, now this is not a full question, so you can read it. So they said, what is the p-value effectiveness with drug? Doesn't really mean anything. I don't even understand the question. So to go back, the type 1 and type 2 error, just to give you some kind of knowledge about this. So there are two types of error that we normally look at. One is called type 1 and another is type 2. So type 1 error means that rejecting the null hypothesis when it is really true. It means that you told, or you wanted to say that, yes, my drug is effective than others. So you said, yes, I reject the null hypothesis. But at the end, it did not satisfy the criteria. That is the time you actually did a type 1 error. So you say that, yes, I have rejected the null hypothesis, and my drug is superior. But then when it was checked, it did not satisfy the p-value, it did not satisfy the criteria. So it means that you actually thought that you rejected the null hypothesis, but you could not. And it means that, yes, null hypothesis was true. Null hypothesis say, yes, you actually did not create any drug which is superior to others. Null hypothesis said that before, but you actually said, no, I'm rejecting it. So when you are saying that, yes, you have done a statistically significant test, but actually you didn't, that's type 1 error. And type 2 error is you could not confirm that your test is superior. So you failed to justify that, yes, you rejected the null hypothesis, but actually it was true. Actually, your drug was superior, but you could not prove it. So failing to reject the null hypothesis when it is really false. So that's called type 2 error. Now, does it really matter if you remember this or not? No. Most of the time it doesn't come in exam, so don't bother. But just try to understand type 1 error means when you say that, yes, I have developed a drug which is superior, you said, yes, I reject the null hypothesis, but actually you couldn't. And type 2 error is you said, no, I can't actually reject the null hypothesis. My drug is not superior, but actually it was superior. Okay. So that's pretty much everything that we normally discuss for stat in the class. You might come across few other questions. If it is, then the other mentors will discuss that anyway. If not, we will discuss that. But this is just the basic that you really need to know. Without the basics, it is difficult to get those questions like right in the exam, because I'm sure like very small amount of you know about public health, or you did a public health master's or something, and most of you don't know anything about it. And for AMC, it is not also the most important subject. All you need to know is like if you can understand what kind of design you need to do, or different studies we have been discussing, if you know how to get a number needed to treat, attributable risk, relative risk, if you know what is incidence prevalence, if you understand 2 into 2 table, if you understand the screening test diagram, it's all that usually comes in exam. And if in exam, if you see a very big stat question, you have never seen it, and you don't have any idea about it, just choose any answer and then go forward. Don't waste too much time. No, it's not must to have an equal number of people. What was that, Dr. Sidra? Didn't understand. Is it possible that in future course regarding recalls course? So yes, you can actually do it, but there is a subscription fee for that. So many of our ex-students, they join our question solve class only. So when we start the new batch in January, yes, we will allow you to do that, but there will be some subscription fee. We will post it in the Facebook group. So if any of you are interested, you can just join that question solve class. And that will be really important, because we always advise you to finish at least few recent months question if you can. Where to study bias? I think there is something related to bias in Kaplan Step to CK, so you can read that. Not a lot of questions come from there. The only thing I have seen is observer bias anyway. So you will only get the question solve classes that you have done in this course. Yeah, I know about the rheumatology and the last class. So I was going to ask, how was the class with Dr. Aruz? Very good, yes. I thought so. So she is really good. I liked how she presented it. She takes a lot of time to prepare the slides, and it's really good to see how she presents and everything. So yeah, that's good. All right, so we'll finish it here tonight. You'll get those videos in your portal. Okay, no problem. Thanks everyone. Take care. Yes, you can do the mock test after 5 months is over. Have a good night, guys. Bye.